So to start off today's symposium, I want to kind of give that 30,000-foot view of what we're talking about today. And the concept is what we call age-friendly healthcare. This came about as a consortium around the Institute for Healthcare Improvement. It's a national initiative. There's hundreds of hospital systems that are enrolled in the Institute for Healthcare Improvement initiative, as well as some local North Dakota facilities that are enrolled in what we call age-friendly healthcare. From a consumer's point of view, they've surveyed people and they say, well, they don't quite understand what age-friendly means. So they've sort of labeled it as better care for older adults. So the concept is that we're trying to improve the processes, many of which we're already doing. And the question is just trying to get our thoughts and our approaches towards geriatric assessment in alignment with ongoing processes, and to make sure that each time we see an older adult in the clinical or hospital setting, that our standards of assessment are applied with each of those visits. So we'll dig a little deeper into that concept here shortly. So the goals today are, would like you to report what are the geriatric 4Ms, and be able to describe what an age-friendly healthcare system, if it's certified nationally, what would that look like? And then also state how the 4Ms, when applied, will improve quality, outcomes of health, and also lower cost. And so a big question is why create age-friendly health systems? So the next slide, please. Part of it is, I think, obvious. We have an aging population. There are some parts in North Dakota, as well as South Dakota and Minnesota, where some of the towns have 33 to 38% of the population is over the age of 65. And so we anticipate this, some people call it the silver tsunami. There's a little bit of a controversy as to whether that sounds kind of derogatory. People don't like tsunamis because they're destructive. But nonetheless, we are having this clear linear growth in the older adult population. So 1 out of 5 individuals will be over the age of 65. And in the hospital setting, over 55 to close to 60% of the hospitalized patient census are individuals over the age of 65. So there's a concentration of healthcare use, as you can imagine, by older adults. So this is part of the compelling reason why we want to improve the healthcare system that is both more efficient, but also more sensitive to patient-centered care around the older adults' needs. Next slide, please. Yeah, so this is a GIF, a GIF that shows how over the time we have what we call the rectilinearization of the population curve. And so you can see that there's a more even distribution as time goes on of the older adults compared to younger adults. Next slide, please. I get a little dizzy looking at that. The other reason that we want to implement age-friendly healthcare systems is to recognize the fact that medical complexity increases with increasing age. And I just want to give a little nod here to this Michelangelo drawing, the Senna drawing that represents medical complexity to my thinking, but it also represents our efforts in our Dakota geriatric program to try to connect imagery with medical concepts. And so we're trying to use art as best possible to provide, I don't know if you want to call it subliminal, but certainly some connectivity with visual spatial representation and our medical concepts that we're trying to convey. Next slide, please. So we know that age in itself is a risk factor for chronic conditions. I actually snitched the slide from a presentation that I'll be doing later this afternoon with our first-year medical students at University of North Dakota. And it pretty much represents the linear increase that occurs with the chronic conditions, so that by the time people are age 65 and older, the vast majority of them have some form of chronic condition, whether that be osteoarthritis, whether it be hypertension. So hypertension is the most prevalent chronic condition. So about 70% or more of 70-year-olds will have some form of systolic hypertension. And interestingly, the number of conditions, so 2 or more conditions, the aging population is roughly split into thirds. 1/3 have one condition, 1/3 have 2 to 3 conditions, and then the remainder third have 3 or more conditions. So there's pretty much an even distribution. And the more chronic conditions you have, the more acute care use you are inclined to have, and other issues for what we call medical complications or iatrogenic disease. So we need to be mindful of those epidemiologic demographics. Next slide, please. I just wanted to point out issue of health disparities. Not that this presentation is, I mean, this would be a whole topic unto itself, but a fairly recent study from the University of North Dakota with some tribal partners identified that chronic conditions in older adults is disproportionately represented in American Indians. And I think we just need, because of the focus of this Great Plains Indian program focus, that we want to give a nod and recognition to this health disparity that's been surprisingly very little in the medical literature that talks about this health disparity. Next slide, please. So the other reason that we want age-friendly health systems is to recognize the fact that older adults are subjected to disproportionate harm. Again, we call these iatrogenic disease, and sometimes unintentional. So for example, we know that an individual who has 8 or more medications has a 100% chance of having a drug-drug interaction. So what if that drug-drug interaction happened to be gastrointestinal problems such as loose bowels? Well, a lot of times a provider will say, oh, okay, why don't you take this? And they prescribe them loperamide or something to slow the bowels down. And so they're treating a symptom that's been created by medications that have side effects, and then perhaps not knowing that highly anticholinergic medication that they prescribe to resolve their bowel situation then causes additional or predisposes them to additional harm, such as acute confusional state or delirium, particularly if they're hospitalized. And so that anticholinergic burden escalates and predisposes the older adult to mental status changes. Next slide, please. Well, this is a big deal, particularly in North and South Dakota. The fall rate, there's been 150% increase in the fall rates overall, but also the deaths due to fall rates are increasing steadily, and we need to recognize that. And as I mentioned, in North and South Dakota, we're amongst the top 5 states for injury and death related to falls. So we really have our work cut out for us if one of our objectives is to reduce fall rates and injury with falls in our in the Great Plains. Next slide. So we also want to recognize the distribution. So there's some gender differences with fall rates that are maybe not so obvious, but there is differences between men and women with the fall rate, and part of that is because of testosterone for men that maintains musculoskeletal system. whereas with women, it's much harder to maintain lean body mass. We know that falls increase with increasing age, so that in the middle there, you can see that 1 out of 3 older adults will have a fall each year. In the nursing home, it's a 50% likelihood that somebody will have a fall. And then also to point out some of the race and ethnicity disproportionate harm that comes from falls. And again, we can see that there are some differences between the different groups. Next slide, please. So I really talked about how polypharmacy, the number of medications that are proportional. So the more medicines you're on, the more likely you're to have disability, the more likely you're going to progress to frailty, as you can see in the left-hand column here. And then with each accumulation of medication, the probability of those medicines interacting with one another increases substantially. So if I can call your attention to the right-hand column here, you can see that there's complex drug interactions, and basically that starts to go exponentially after the 8th prescription. So all you have to do is just simply count, and if somebody's on 8 or more medications, you know that there's a pretty much a 50-50 chance that some of the symptoms that they're expressing to you are related to their medications. Next slide, please. This is really a big deal. We as providers don't do such a great job in identifying people with cognitive impairment. There's a variety of reasons for that. Here you can see the an artist who started off drawing when he was cognitively intact and did self-portraits progressively. And you can see the deterioration of his self-portraits as his cognitive impairment progressed over time. So this set of drawings reminds me that with cognitive impairment or Alzheimer's disease or any form of dementia, that visual spatial changes are amongst the first brain changes that can be recognized. Next slide, please. So the question is, with an increasing adult population, with increasing vulnerabilities, what is our solution? What do we have from the healthcare angle to address all of these issues in the background that I just presented? Next slide, please. So there's a couple of ways to do this. As a geriatrician, I say, well, you could have geriatrics guided healthcare, but there are not a whole lot of geriatricians circulated around the United States. In North Dakota and South Dakota, each state has about a shortage of about 40 to 50 geriatricians across the state. If you were to have an ideal arrangement with that subspecialty care. So that doesn't exist. We're trying to train some geriatricians through our fellowship program. We have 2 geriatric fellows a year, but it's going to take 20 years to get enough geriatricians into the state, and there'll probably be several retirements by that time. And so it's always a steady state of trying to repopulate the geriatric expertise. And so our solution is something along the lines of what we're doing today, is to create a better trained healthcare workforce, which is in the right-hand bottom corner here. And then the focus is on what we call age-friendly health systems. You can see the symbol or the emblem here from the Institute for Healthcare Improvement. And we'll, with the next slide, just show the concept of where age-friendly needs to occur. And so you might say, well, it's in the hospital. Well, yeah, that's in the middle here with the acute care. But actually, age-friendly healthcare goes across the continuum. And you can see that this graph that shows increasing acuity over time, that the best places to apply age-friendly healthcare are in the clinics, in the hospital, as well as in long-term care facilities. Next slide, please. So the age-friendly, excuse me, framework started off with a group of experts and content experts, and they firstly analyzed the different geriatric models of care. I had pointed out in an earlier slide about the ACE program, so that's an acute care for elderly program. And these experts basically gathered what they thought were the best practices, and they consolidated all that evidence and said, well, which are the best ones? And so that's how they came up with the age-friendly framework. And so the age-friendly framework are the 4 M's. And so this is one of the goals that we have for today's presentation, is to be able to report what those 4 M's are. It's what matters. So the matters is the first M: medication, mentation, and mobility. And for each of these, they're practiced as a set. Okay, so when you see an older adult in clinic or in the hospital, there should be a list of these 4 M's with each daily or yearly encounter, so that you can report what's changed or what's either improved or not so with each of these 4 components. Next slide, please. So the Institute for Healthcare Improvement tested these geriatric 4 M's in both the outpatient setting and in the hospital setting. And they did so through a quality improvement technique where they planned, they implemented the program, they studied it, and then they said, let's implement it or act on it. And that's the sort of usual process for quality improvement or continuous quality improvement that's applied both in the clinical as well as the hospital setting. And I might add that they did not look at long-term care, but I think that's an important element that needs to be added to this because in long-term care, we also have primary care. Next slide, please. So to emphasize that the geriatric 4 M's need to be practiced as a set, that they need to be adapted locally. So for what that means is that if you're going to evaluate mobility in the older adult and want to evaluate their fall for risk, some people will use the what's called the Sharpen-Romberg test, which is just a front foot tandem stance, where others may use the timed up and go test. Whereas others, in our case, at Sanford Fargo Clinic where I work, we use gait speed. And so if somebody walks less than 1 meter per second, they have a pretty high risk for falls. And then we do our assessments and interventions from there. So that's what is meant by adapting your assessment processes locally. What makes sense to your clinic? What makes sense to your hospital? Out of this menu of different ways that you can assess things like mobility, unsafe medications, and so forth. Next slide, please. So importantly, we want to understand what the health goals are for older adult. And so that first M, the what matters part of it, really requires a better understanding of what the older adult wants. I can give you an example where I had a patient come into clinic. It looked like she had a urinary tract infection, and I treated her empirically. She said, "I'm done with testing. I don't want to go to the hospital." So she was expressing to me her wishes, and so I sent her home, and later found out, or I got a report, because they message you in the electronic medical record that she was hospitalized. And I looked at her medical record, and she was sent to hemodialysis. She went to the ICU, and oh my gosh, I mean, it was just a nightmare of things that happened to this woman. She survived. And when she came back to my clinic, she's wagging her finger at me. She says, "I told you I didn't want to go to the hospital." And I said, "But I didn't send you to the hospital. I think it was your daughter." And so there was a disconnect between the patient representing what she wanted to her family, and the family took charge and put her in this acute care setting, none of what she wanted to have. And so we had a family meeting afterwards to better understand the healthcare goals, and we documented that do not hospitalize in that particular instance. So it's important in step 3 here is to align the care with what the older adults' health outcome goals might be. And this is a dynamic process. It changes from time to time. I know that, for instance, the PULSE document, the physician order set, changes within 2 years of its initiation. So this is a very dynamic process. Next slide, please. In terms of body and mind, we look at mentation. This poor Michelangelo figure is getting nipped by a serpent on his leg, and he's in quite a bit of distress. And so cognitive changes, mood changes can be a form of stress in older adults, as well as their family members. Next slide, please. So we want to do an assessment of depression, anxiety, cognitive impairment, and delirium, particularly focused in the acute care setting for delirium. And we want, if there is a screen positive, let's say for cognitive impairment, we want to look at what the non-pharmacologic as well as the pharmacologic interventions might be. So again, this tandem, you do the assessment and then you do the intervention or management plan with each of these 4 M's. Next slide, please. In terms of medications, we're focused on de-prescribing. And so typically we use what's called the Beers list for identifying medications such as benzodiazepines, opioids, and anticholinergic medications such as Flexeril or cyclobenzapine that are highly anticholinergic, and even Benadryl, right? So diphenhydramine is highly anticholinergic and can put an older adult at serious risk for delirium. Next slide, please. In terms of mobility, the goal is to have the older adult move safely. We'd like to improve their function if at all possible. And ultimately, by improving their mobility, that'll help support what matters to that older adult. So again, these 4 M's are intertwined with one another. So in the clinic and hospital setting, excuse me, you want to assess fall risk. Excuse me, I had to clear my throat. You want to assess fall risk as well as what their functionality is. And so measuring their functional impairment, if any exists. And by doing this, you want to intervene and have a mobility plan. And so that mobility plan may be reducing hospital sedentary time. I don't know why we put people to bed in the hospital. This concept of, that you need to rest and recover actually is detrimental. For each day in bed for the older adult, it takes 3 days of recovery. And so that whole concept of just, getting somebody, to rest insatiably is really detrimental to their health. We also want to have a mobility plan that includes resistance training as well as aerobic training to prevent falls. And ultimately, we would like to increase their function, whether that be their activities of daily living or their instrumental activities of daily living. And there's a wonderful program at University of Chicago where they identify people who are pre-frail, they're not quite frail yet, and they put them into a physical therapy program and a mobility program, and actually in 60% of the cases can reverse the frailty process. So it's quite dramatic. Next slide, please. So as part of the mobility plan, we want to create safe home environments. And so doing home assessment programs may be important. Having a mobility plan or a goal is important. And then I think also equally importantly is to monitor that. And so that may be a phone call to the older adult. Are you doing your 5,000 steps a day, or have you gotten to your goal or not? And to keep track of what they're doing. Are they doing any type of resistance training at least twice weekly? So those are all questions that we would like to follow up on. Next slide, please. Just a brief mention that the concept of age-friendly start small. So you might have 100 patients that you apply these concepts to, and then you scale it up. So you might do the 60 to 70-year-old population, and then go from the 71 to the 80-year-old population, and just keep applying these age-friendly assessments and interventions over each group. Next slide, please. So to scale up, you need to firstly demonstrate that you're able to practice these 4Ms together as a set, and that they're practiced reliably. When I look at my own clinic, I do a self-assessment, and I go back, I said, did I do the 4Ms? And here I am, a geriatrician, and I would say 1 out of 3 patients, I forget to put the 4Ms in. I was just so busy. And that's the whole point, is that you want to do some reflective thinking about whether you're applying the 4Ms or not. Next slide, please. So the question then is, where do we get started? And I think the good news is that a lot of what we're doing is already in place. A lot of programs are already doing PHQ-2 for depression screening, for example. Maybe you just need to add the mini-cog test as part of the cognitive screening. So there's a lot of flexibility here. And again, identifying which tools you want to use for assessing the 4Ms is entirely up to your clinical or hospital operations. And we can advise, that's part of our goal, is to help you decide what the best practices are and what might be the easiest. Next slide, please. So I just want to show you that the 4Ms work. Next slide, please. So that's the question. Yeah, so the answer is yes. This came out of 20,000 patients when the 4Ms were applied at a large healthcare system in Chicago. And you can see that the length of stay for hospitalization was reduced by a little over a half a day, which is a considerable impact, both financially and giving time back to the patient. Next slide, please. So there's other data, just by looking at the question of asking the patient what matters, you'll lower inpatient utilization, you'll shift more towards palliative and comfort care rather than futile acute care. Next slide, please. In terms of mobility, a fall injury in the hospital adds incredible amounts of costs. And it increases the length of stay. So having a fall prevention program is critical in the acute care setting. And it's also critical to the outpatient setting to avoid injury and death. Next slide, please. In terms of mentation, we know that unrecognized depression doubles healthcare costs. Little known, more recently identified, is that people with memory impairment cost the healthcare system and the patient twice as much as a cognitively intact older adult. And if you have a delirium detection program and intervention, there's a credible return on investment for those from the so-called C-suite that like administrative returns on their investments. Next slide, please. In terms of medications, we try to avoid adverse drug events. And you can see that this network that Medicare engaged in had reduced drug events and saved over $78 million across 3/5 of the states in the country. Next slide, please. So to implement age-friendly is that we want to fundamentally transform clinical practices in both primary, acute, and I would add long-term care. And in doing so, that's a workflow and a process that needs to be discussed with the staff, clinicians, as well as with the patients. What do they expect? I mean, a lot of times people come into clinic and, you test the mini-cog and they go, wait a minute, what are you testing my thinking for? So you have to prepare them for what the 4Ms are. And that's part of the education. So on the right-hand column here is that we would like to strengthen geriatric practices. Why would you, for instance, want to use gait speed? Gait speed might be pretty simple to apply, and it's got an awful lot of information related to it. Next slide, please. So basically what we're looking forward to for those who have not enrolled in Age Friendly is to consider joining the Institute for Healthcare Improvement Action Collaborative. You can either do it in the spring or in the fall as part of the national collaboration, or you can do it individually at your own pace. And then that's, in either way, you can connect with our Dakota GWEP program, where we can provide you with advice as to how to best implement these geriatric 4Ms. Next slide, please. So what about the geriatrics training? Just want to quickly walk you through some of the different offerings that we have. Next slide. So engage the GWEP. So I'm a Star Trek fan, so I always like Captain Picard telling us, engage, and let's get to it here. Next slide, please. So we have a variety of programs that we can use for education. Next slide, please. And some of those are online curriculum that are going to be posted shortly and associated with the digital badge that Dr. Manotka mentioned earlier. Next slide, please. If you go to Age Friendly on Instagram, as you can see down at the bottom left here, we have social media postings for geriatric knowledge. Those are kind of fun, and we're trying to tie art into geriatric clinical pearls. Next slide, please. We have monthly ECHO programs, so we're reviewing the geriatric 4Ms. You can go to our website there in the lower left-hand column there and access the schedule for the second Tuesday of each month at noon. Next slide, please. We're trying to create some population health educational tools. Hopefully by the fall, you'll be able to play this Geri population game. We call it Geri Pop. And we'll see how that goes. It's a work in progress. Next slide, please. We also have webinars much like this. So this is an example of how we do our presentations. We're also anticipating in June what we call a dementia friendly to complement the age friendly process here, and ramping up our efforts to recognize and manage people with cognitive changes. We try to avoid saying cognitive impairment, but as clinicians we know what that is. But to try to put a more positive spin on that is older adults with cognitive changes. Seems to be a little less ominous. Next slide, please. So we have a variety of educational programs. We partner with senior centers, Memory Cafe. We're trying to connect with faith community nurses, and we're developing a curriculum for caregivers. Next slide, please. So just to summarize, it's important if you adopt the geriatric 4Ms to practice those on a regular basis with each clinical encounter. There's an opportunity to partner with the Dakota GWEP for improving geriatric knowledge, and we're willing to adopt or adapt our training methodologies to suit your clinical operations. So for example, we have a PDQ geriatrics that we did with one of our tribal partners, where it was a 15-minute presentation on how to best do mentation assessments. I think, was there one more slide? Yeah, so just as a quote from Thomas Paine, basically the bottom line is that we're used to doing what we're used to doing, and it takes quite a while, the tincture of time, to really change our minds, but time wins, and we will change. So hopefully I've convinced you today that applying the geriatric 4Ms is an opportunity for that kind of change for the better.